As opioid availability is one of the important topics that we have to listen to. I understand we have had a session on organizing palliative care services, and in many of these, or the questions that came up during the session was about sometimes the barriers to availability of opioids. It can be from barriers at any level, from personal level as well as from the administrative level. Sorry, I'll just mute that. Just give me a second. Sorry for that. So today for our session on opioid availability in India, we have Dr. Savita. Dr. Savita is a commandant in the Border Security Force in Academy at Gwalior. And she has done her post-graduation in palliative medicine, MSc in palliative medicine from Cardiff University, UK. And she is honorary secretary of Indian Association of Palliative Care. And she is the founder I think it's the first website on bereavement support in India, and she's also have launched e-hospice India, and a lot of publications. And she's a very active member in Indian Association of Palliative Care. And thank you so much for agreeing to be a part, Dr. Savita. I think it's been so long. None of us have met each other after COVID, so it's good to see you virtually at least. Welcome to the session.
Thank you, Sridevi, and good evening, participants. I hope I'm clear, because I would like to tell everyone that I'm in an area with a very poor connectivity. I've been transferred to Tripura right now. I'm in the middle of a forest. So if my electricity goes off or if I have a problem with my connectivity, then please bear with me. So shall we start now?
Yes, Dr. Savita.
Yeah. Yes. So, okay, so as Sridevi said, this is one of the important sessions because we will be talking a bit about the issues with availability, and we will be talking a bit about how to make opioids available in your institutions, which is one of the important aims of all trainings that we do for palliative care. So when we talk about why we need opioids, I'm sure people must have done this session with you earlier about the need for opioids. We have a huge unmet burden with not only advanced cancer, but also patients with HIV, those with AIDS, especially CHF, COPD. All of these patients need opioids for the severe pain that they have, because it affects not only their physical but as their social beings, their families, their communities, increases the existential distress, doubles the risk of suicide, and makes life miserable for the families as well as the patients. My light's gone. Can you see me? Can I still go on with the slides?
Yes,
ma'am.
Okay, so there's a huge unacknowledged pain burden, and there are many studies regarding this which I have quoted and you can go through. But the ironical thing is that opioids have been included in our national list of essential medicines since 2003, and still most of our institutions do not have access, although they say that pain relief is a fundamental human right, and not giving pain relief to our patients when we do have the means is the same as torturing a person. All over the world, it is the developed countries which consume almost 80% of the morphine which is legally made, and poorer nations with the developing countries, the population which is huge and the burden is huge, but they get only about 6 to 8% of the legal opioids. And though opioids have been on the WHO's list of essential medicines since 1985, and in our country also, as I mentioned, since 2003, the domestic consumption is very little because of a lack of training. People are not aware, and we do not prescribe it too much. It's mostly exported, and it's a very cheap drug. You must have come to know by now that opioids are very cheap, especially oral morphine is very cheap, but there's a lack of demand because people are scared because of this fear that we have about use of opioids leading to addiction. And earlier there was very stringent laws. Thankfully, they've been modified now. The UN resolution, which was passed in 2005, mentioned that medical use of opioids is indispensable for the relief of pain and suffering, and that it should be available at all times in adequate dosage forms for our patients. And any country with a low national consumption is a matter of great concern. So where does India stand? This is a figure by the Pain and Policy Studies Group, University of Wisconsin, which shows where the global consumption of morphine per capita stands for Australia, for US, for UK. And if you look for India, you'll have trouble finding where India is. India is somewhere here low down the list. Also, when we look at figures for patients who need morphine or oral opioids in the last 3 months, for cancer and HIV, almost 80 and 50% patients need it. The average requirement is 679 milligram per patient, and the actual use in India is 0.4 mg. So you can imagine how underused these medications are. Again, the Pain and Policies Study Group, it developed morphine equivalence metric for 6 principal opioids adjusted for the population. And for Southeast Asia region, it was around 1.7 milligram per capita, whereas for the European regions, it was around 170. India has only 0.22% of adequate level as per 2010 data. And the barriers for a long time have been lack of education, training. There were problems with the legal issues which were required. And patients also are sometimes reluctant to take opioids because they fear that this is the last drug which is available to us. So giving morphine means they're going to get addicted, or that we have nothing more to offer to them and it takes away hope. Also, complex procurement process and the procedural delays because of multiple agencies which were involved, and misconceptions among professionals who need to use it, and the fear of harsh punishments has been responsible for this over the years. If you look at a very interesting article by Dr. Nandini, it tells us that the historical reasons why opioids have been so feared and not used, it actually started with the opium trade. When British were occupying Southeast Asia, then there was a lot of problem with the opioid addiction in that time, and India was a major producer under British rule, where Myanmar, Thailand, and parts of Bangladesh formed the Golden Triangle and were involved in illicit trade. Ultimately, the laws that were passed at that time led to opium wars, and there was a civilized closure to conflicts in the 20th century, but those rules which resulted in the opioid use coming under the revenue department. I have myself often wondered why opioid being a drug is controlled by the revenue department, and later on came to know that this is the reason why we had problems with the medical use. So it's an interesting perspective if you're interested in reading. The NDPS Act of 1985, it was a huge act, as you can see in the book here, and it led to a lot of problems because there were multiple licenses, there were multiple agencies involved, and it discouraged hospitals from using opioids, and the punishments were very disproportionate. I will not go into the details, but I have put them in the PPT for you to understand. The Pallium people will share it with you so that you can go into the details and see why, owing to our traumatic past, Southeast Asian countries interpreted these laws more in terms of restricting illicit use rather than encouraging medical use of these opioids. Also, there were problems with the licenses. We needed about 6 licenses earlier, and there was non-uniformity of the laws among the states. And a number of offices were involved, the excise, drug controller, and there was lack of coordination between these offices. There was a lot of resistance to the change. And a lot of follow-up effort was done by NGOs, by the civic society, by the Indian Association of Palliative Care, Pallium India, which has finally led to changes in the law. And finally, now we have had, okay, I will not go into the details because this slides I had put up just for you to read. And problems with manufacture, I would like to mention that if you take a look at this table, which shows the cost of the drugs, you will see that the drugs like morphine, they are the cheap ones, but tramadol, which is more easily available, fentanyl, which is more easily available, are the ones which are expensive. So one would normally think that the cheaper drugs should be easily available, but that's not so, because the pharma companies are not there for social service. They are there to make profit. And you will find that although the rules remain the same for tramadol and for fentanyl patches, most of the institutions will have these, but they will not have oral morphine. Whereas the WHO says that no institution should have access to these drugs unless you have oral morphine available. When we were studying pharmacology, we all read about the problems that morphine causes in terms of addiction. And we grow up learning that it should be probably used when only patients are dying. It hastens death, it causes respiratory depression, lots of side effects, and the fear of addiction is always there at the back of our minds. But this remains an important factor in underdosing. However, the studies show that drug addiction rarely occurs in patients who receive morphine for medical purposes, and lots of studies are there. The data is there, which shows that they are safe when used by properly trained people for patients under supervision. What is the evidence for their safe use? There was a study at Thames with almost 12,000 patients. Another study was there in Kozhikode, which was published in the Lancet. All these studies show that there, if you use the drugs properly by trained people, there is a very little scope for worry. Now, what happened in 2014 was that the NDPS Act got modified, and this has now become the law, and it's a central law. That means all the states need to ensure uniform implementation of whatever is there in the NDPS Act of 2014. The central principle of this act was that there should be a balance in the use of opioids for patients and for preventing the diversion for illicit use. It upholds the fact that access to pain relief is essential. Opioids are safe and effective, and we need to strengthen and integrate programs to control misuse, as well as for training and simplifying procedures for the procurement across the country. So what does this modified NDPS Act of 2015 say? It basically simplifies the procedures which are required for stocking and dispensing, and it avoids delays and interruption in supply. The whole process reduces the hurdles which were there earlier. Then there's a short list of essential narcotic drugs which have now been notified. We will come to it later. It also defines the uniform rules which are applicable across the whole of India, and it authorizes one state level agency, that is the drug controller, the state drug controller, to recognize the institutions and to give permission for use of opioids. It allows the stocking and dispensing of opioids for a period of 3 years, and it does away with the multiple licenses that were required earlier, so that any institution which needs to have opioids requires only one permission from the state drug controller. Now, to make things slightly more systematic, we will go one by one. So I'll just tell you briefly the terms which are used. What are the definitions which we need to know as per the NDPS Act rule? First of all is what is essential narcotic drugs which are defined under this Act. Medicines controlled by the NDPS Act, identified with a notified list. There's a limited number of opioids which are necessary for pain management as approved by the drug controller in India, and these include 6 drugs: morphine, methadone, codeine, hydrocodone, oxycodone, and fentanyl. So people who are new to this subject, I would just like to tell you that in the West, there are a number of drugs, there are a large number of opioid drugs which are available. But in India, we have only 3 drugs as of now. And these 6 drugs are there listed, out of which only 3 are available. And who is a registered medical practitioner? We will come to it why we are talking about these terms. First of all, I would like to just tell you briefly about it. Any registered medical practitioner defined under this act is a person who is registered as a medical practitioner under the Indian Medical Council Act, or as a dentist under the Dentist Act, and who has undergone training in the medical use of ENTs. So any doctor, MPS doctor, or any dentist who is trained for the use of ENTs is a registered medical practitioner for practical purposes under the law. And what's an RMI? A recognized medical institution which can store, stock, distribute opioids, that is called an RMI. So a medical institution, any hospital, dispensary, clinic, or institution which offers services for diagnosis, treatment, care of disease, injury, abnormality, and established by the government or municipal corporation, municipal council, Zilla Parishad, or any person or body of persons. So legally, this would include any kind of hospital or dispensary or clinic. And this can be recognized by the state drug controller for purchasing, possessing, and dispensing ENDs, that is essential narcotic drugs. So any person who is working in a district hospital, in a Zilla Parishad hospital, in a PHC, and has undergone training can get an RMI status for that institution. So government hospitals are deemed RMIs, that is by the virtue of their being government hospitals. If they have a trained person, they are deemed RMIs for stocking and dispensing opioids. So how can we get opioids into the institution? Any healthcare facility can purchase, store, dispense oral morphine once it conforms to these rules. That is, what are the rules? Having an officer in charge of ENDs. So any doctor or any dentist who is trained can be deputed as officer in charge. They should have a facility for safe storage of narcotic drugs. That is a secure facility to store them in a cupboard with a lock in a locked room. So it is called a double locking system. Now this does not mean a locker-like cupboard like we have in the banks with 2 locks, one person having a key of one lock and the other person having another key. It's not that. Some people interpret it as a cupboard with 2 locks. It's not that. It just means a locked cupboard in a locked room. So just basic staff should be available for noting down the drugs which are dispensed. It can be either a nurse, it can be a pharmacist. You just have to have a person who is trained to document these things properly. And we will come to the one by one, we will come to what are the forms which are required. Whenever we prescribe opioids, the prescriptions need to be in a proper format. What is that? It shall be in capital writing. Now, practically, I don't know, this is so difficult to do. If you're seeing 50 patients and you have to write prescriptions for everyone in capital, it is difficult, but it is required legally. One thing is ensures is clarity of the name, clarity of the drugs, clarity of the doses. So that is why it says capital writing. It should have a date. It should be signed by the doctor who is prescribing with full name, address, and registration number of the RMP, that is the registered medical practitioner. The name, address of the person for whom the drug is given, the patient's name and address, what is the total quantity of the drug which is given. Like if I'm prescribing 20 milligram of morphine QID for say 15 days, then how many tablets in all? What is the daily dose? Duration of the prescription, whether it is 2 weeks, 3 weeks. We generally practically do not give for more than a month. Records should be maintained in the format described in Form 3E. We will come to it later. And a prescription which has been given is usually kept in the hospital for a period of 2 years. This is important. Must maintain these records for a period of 2 years. And even if you're a standalone practitioner, or like I am there, in my hospital, I keep getting transferred from one place to another. I keep a copy of the prescriptions with me for a period of 2 years. How do we get our hospital or our institution recognized as an RMI? So what I have covered earlier is what are the 6 narcotic drugs which are recognized under the Act, what is an institution, what is a recognized medical institution, and who is a recognized medical practitioner. Then what is the process? First of all, you need to have somebody who is trained in the medical use of ENDs. Now, the requirement of training, whether it is 3 days, 10 days, 2 weeks, 1 month, it is not specified under the Act. But practically, we prefer that at least for 10 days is the minimum, and preferably for 4 to 6 weeks, if a person can be trained, it is good. State governments, when they send people for training, they can send for as little as 3 days sometimes, but it is not enough. So training in medical use of ENDs, somebody should get trained. Then the hospital can apply for an RMI status. I'll come to the process of application. You have to apply to the state drug controller. They will send somebody for inspection after they get the application. After inspecting the institution, they will authorize that institution as an RMI. After they have authorized, the institution can start the process of purchase of narcotic drugs, get a receipt of the consignment, and then they can start stocking and dispensing. Maintain proper records like we maintain for all our drugs in the pharmacy. You have to file an annual return also and see if the status needs renewal. It is usually for 3 years. Sometimes you may need more medication that you can apply in between also. So this is the basic process that we follow. Now we will go into it one by one. First of all, as I told you, somebody in the institution needs to get trained. So either a doctor, MBBS doctor minimum, or a BDS person from the institution can get trained. After the person is trained, the institution can send an application, which is sent in the format of Form 3F. These documents are all available on the net, but I think I have put them in the end of my PPT also, and I'm sure Pallium will be providing you a list of the documents which are required when you apply for RMI status. So apply to the state drug controller, and this application is sent by the authority in charge of the institution. Whoever is the MS or whoever is the senior doctor in the hospital, they will be sending this application. So what are the details that need to be sent with the application? Who is the doctor who is trained? We send their name, we send their MBBS or MD or MS copy of their certificates. We send a copy of their training, and we send a copy of their registration with the medical council. There can be more than one person also. So for all of them, we need to send their degrees and registration certificate and training certificate, 3 things. So forms are filled with the Form 3F, Form 3J, that is the annual estimate of how much drugs is required, a covering letter, and a self-addressed stamped envelope for ₹27. Now, I don't know what 27 rupees stands for, but it is what is given in the law, 27 rupees. I know this is getting a little bit like forensic classes, but please, I have tried to include all the things that you will be requiring when you actually go on for the process of getting opioids for your institution. So it might sound a little droning and boring right now, this this presentation that I'm giving you, but believe me that all this compilation of the documents and the process does prove helpful for people when they are actually applying. After that, once you have sent your application, the drug controller or a designated person from their office will come and inspect the clinic. Once you send your application, they are supposed to uh, write back to you, and not later than 2 months from your application, they are supposed to give you a reply. Uh, they will tell you what is the quantity of essential narcotic drugs which they have allotted to you. And if they do not give you permission, then they have to give you a reason within 60 days why they have not permitted. Once you get approval, you can fill and submit to the approved pharmaceutical agencies along with a copy of your RMI certificate. There is a list of approved agencies. There are many agencies which make opioids, and there are good companies. They are listed on the Indian Association of Palliative Care website also, along with contact number of the companies and retailers in different states, so that people who need to get medication, they are able to do it. And I must tell you that for people who are from the government sector, you would be interested in knowing that we are in the process of talking to Government Medical Stores Depot, GMST, from where we are all supposed to get our medication from, for including opioids in their list of medication, so that it becomes easier for medical colleges and government hospitals to get opioids through the GMST stores. So after you have filled and submitted your order of purchase, once you get a consignment, the applicant will get original consignment of the drugs along with a copy of format form 3C. So original is retained and a copy of it is returned to the supplier with the signature of the person who has received it. And the important thing is maintaining of records. Sometimes people just don't get opioids into their hospitals because they think that maintaining records of opioids is very difficult, but it's not. Believe me, it's as simple as maintaining the record of paracetamol or digoxin or steroids that we have in our hospital, and we don't leave lying around here and there. So all records have to be maintained for a period of 2 years. And there is a detail. I'll show you how to maintain the registers for everyday transactions when we give out from the dispensary. Then what is the format for maintaining the transactions? We have to keep a separate record of every patient to whom the END was dispensed in the format of Form 3E. And file a return for the calendar year before 31st of March. Now, these are again in the form of 3I to the controller of drugs. We must keep the opioids in a closed, safe cupboard. The quantity of each drug should be entered in the specific section of your register. Have a separate register in the dispensary as well as the store. And if you have, say, different, you have 3 kinds of drugs, like you have injection morphine, you have oral morphine, you have fentanyl. So keep different entries for all of them on different pages, or separate registers for each formulation. Day-to-day entries should be looked into. The medical officer who is in charge, I think that goes for all medication. The store in charge is supposed to be the person who is actually looking into the day-to-day entries and signing the stuff. But the name and address of each patient has to be registered along with the quantity which is given. At the end of each day, the total quantity of the ENTs dispersed that day must be maintained, and this forms the initial quantity for the next day. It is subtracted from the total initial quantity with which the register was started, and this amount is the initial quantity for the next day. Now, what about private practitioners? If you're a standalone practitioner, can you have ENDs in your own clinic? Yes, you can. Any RMP, any registered medical practitioner, that is any doctor who's trained in palliative care, can have a stock of ENDs, a small stock for emergency use. Morphine 500 mg, not more than 500 mg. Codeine, not more than 2000 milligram. Hydrocodone, not more than 320. Fentanyl, 2 transdermal patches of 12.5 or 1 patch of 25 microgram. And oxycodone, not more than 250 milligram. these are the quantities an individual doctor can have in their clinic for emergency use. But it is important for the police, for the policymakers, for lawmaking agencies to be aware of these rules, because I have seen doctors in Ludhiana, a person who was dealing with de-addiction had a lot of problem because they were stocking buprenorphine in their clinic. And we need to, whenever we are doing these things, we need to make our colleagues aware, we need to make our agencies aware of why we need these drugs and what are the rules, because the policeman who is standing next door does not know these rules. If the stock is finished before the year is out, we can apply again using Form 3B to the State Drug Controller and receive special permission again for a period of 3 years. You can repeat order of purchase during the year if it is required, if there is an increase in the number of your patients, but you need to revise the annual estimate and submit it by 31st August of each calendar year. This is a picture showing how the entries are made. These are the names, these are the dates, these are the names of patients and quantities given. This is a photograph of a register's page with the entries of the drugs. But it's also important that we purchase our drugs only from authorized chemists or dealers. And this list should be available with the State Narcotic Commissioner. If it is not there, we can write and tell them to make it available. And if in case of an issue, do talk to Pallium, do talk to IAPC. There are people who would be happy to help out with availability issues. But make sure that they are prescribed and given only to selected patients under supervision. And it is also important that these narcotic drugs cannot be transferred, loaned, or sold to other institutions, except with the written permission of State Drug Controller. Now, what does this mean? I'll give you an example. Like I was in Pekanpur and got posted to Tripura. So we had about 700 milligram of tablet morphine left there. And after I left, there was no doctor who was trained for its use. We could have shifted those drugs to the state regional cancer center, but we need to do it with permission. So an alternative, what we found was that we asked the oncologists to refer the patients to our hospital instead of our sending the medication there, which was more complicated. So that the medication should be used for patients who need it. Unused ENDs can be returned by the patients to the institution if the patient dies, or if you stop prescription of morphine in a patient who has improved. The unused opioids can be returned to the dispensary and they can be taken back as receipts. They can be added to our total stock. If they expire, they can be destroyed only in the presence of an official designated by the State Drug Controller. We cannot destroy ENDs on our own like we do for other drugs. And any change in the state of RMP in charge, like I got transferred, then I needed to, our hospital needed to intimate the MP State Drug Controller that this doctor has got posted out. We have a new doctor who is a psychiatrist and trained in palliative care. He is going to take over. Any change has to be intimated within a month. If you need to renew your application, it is usually for 3 years, but say I applied in 2015, my license finished in 2018. So that application for renewal has to be sent before 30th of November each year. And you have to give the balance of ENDs from that year's stock. Details are there, what all you need to give, but make sure that you plan for your ENDs to cover the requirements of at least 3 months. Sometimes the supplies get interrupted and the patients who are on opioids, if they don't get their medication, they'll end up in very, very severe pain crisis. So make sure that you have enough medication when you order it. And 3 months buffer stock should be maintained in the hospital. We also need to be aware when we talk about increasing availability of opioids, that principle of balance we must keep in mind. We must learn from the experience of other countries. Countries like US, which have easy access to opioids, have seen problems. In North America, there was a huge epidemic of overuse, especially in non-malignant conditions. So we need to be very, very cautious when giving out drugs for non-malignant pain. I have seen tramadol being used left, right, and center for low backache by orthopedicians, used for TID for 5 days, for a month, and then suddenly stopped. Please remember that drugs like opioids, like even like tramadol, can result in dependence with even a use of 7 days. So it is not that we are not using it, we are using it, but we need to use it cautiously under supervision. And if you need to stop medication, then please taper it off. Do remember that even with tramadol, patient can land up in withdrawal symptoms. So we are not going to stop using, we only need to be cautious and we need to be aware. We need to give it carefully. We have to learn from the fact that there was a huge epidemic of misuse in other countries. We don't want that status to come to India. The circle of safety is something which is advised by people who are using opioids, that whenever we do prescribe opioids, first of all, win the trust of the family and the patient, make them aware that this is not something ke maine khai thi main theek ho gayi to tum bhi kha ke dekh lo. This is not something to be given to patients lightly. It is not to be given to anyone except the patient for whom it is prescribed. We need to empower our physicians, train them properly, make them comfortable with the use of opioids. See, it is not something to be scared of. It is just something that you need to use carefully. We use digoxin, we use steroids, we use insulin, we use so many drugs, we use cardiac drugs which need to be used carefully. Only thing is proper record maintenance, proper documentation, and proper training. That's all. Responsibility whenever we give opioids, it rests with us, and we need to be careful. But make sure that availability is there. Educate your staff. Make sure that safe dispensing process is followed in the pharmacy. Supervise the staff properly, the nurse or the pharmacist, the family which is actually giving out the drugs at home when the patient is in home care. Make sure they know, they understand, give them instructions in the local vernacular language. Make sure it is kept out of children's reach. It's not used for anyone else. Tell them the side effects when they are starting. Tell them if the patient dies, don't burn, don't bury the drugs. Please give them back to the hospital. It will be used for somebody else. But use them safely, use them nicely, and you will see what a lot of difference it makes to the patient's lives. Select the right patient. See whether it's actually pain is opioid sensitive, whether other psychosocial issues are there, solve them. And the aim whenever we give any kind of analgesic is that we need to see improvement in function, quality of life. And strong opioids are not the end of everything. It is not that all pain can be controlled with strong opioids only. But do look at non-opioid inputs for analgesia. And opioid therapy for long term should be continued only if it is clinically meaningful for your patient. If it actually helps them improve their function, quality of life, and it outweighs the risks to the patient. Use them short term and start with normal release preparations. I'm sure you've been told all this, but I'm just revising. Don't start with slow release or transdermal preparations. Always cover side effects prophylactically. And as soon as possible, as soon as the patient you think is improving, try to step down. Don't continue long-term and non-malignant pain unless and until you are very sure. Don't assume the patients know how to use it safely. Don't abandon patients with a prescription drug problem. Even if patients have an addiction issue, we are supposed to give them pain relief, but then we take into help psychiatrists, counselors, families, take their help and continue. Then best practices, read them. I would suggest not going into this right now, but I have put them in the slide. Go through them. Just keep them in mind that if there is an abuse potential or aberrant behavior, keep an eye out for that also. But don't stop when the patient needs analgesics. Just we need to manage them better. Check whether the patient is adhering to the drugs properly. And remember that morphine, simple plain morphine, oral morphine, after all these years, it remains the gold standard all over the world. There are other drugs available, but for developing nations and poor countries like India, it is still the best, the cheapest, most effective drug. And do remember that we give opioids according to the severity of pain, not the stage of the disease. Patient with even stage 1 cancer may have very severe pain. So it is the severity of the pain which determines the use, not the extent of the disease. And again, as I mentioned in my first opening slide, that no institution should have expensive formulations unless it has access to oral morphine. This is the take home message. What is the present status? Present status practically is there that the law has been implemented, but availability still remains problem for most of India because people are not aware. Even people within narcotic department are not aware. And punishment continues to be disproportionate in relation to the error. We are trying within the palliative care community, people are trying to get things sorted out again. But with this batch, with every batch, we hope that we will try to integrate pain relief, palliative care into our work at all levels. Whatever you do, whether you are in medicine, pediatrics, psychiatry, gynae, orthopedics, or you're into counseling, you're a dentist, there are people who need palliative care. They need that approach. So we need to integrate into primary care, secondary care, tertiary care, wherever you work. And when you get trained, try to create awareness for others, for health professionals, for your patients, for the general public, for policymakers, police organizations. So we expect that when you go out after this course, you will create awareness in your own communities and in your areas of work. Try to network with support groups, with the community, with educational institutions. Religious and political groups can be very helpful in influencing communities. NACO, NGOs, media, they're all very helpful. And education and training. I'm sure you know that now we have started with the DNB, we've started with MD palliative medicine. A number of workshops, distance e-learning courses are available. There are online resources for people who are interested in increasing their knowledge further. And evidence-based practice is something we always push for. So when you go back, look at the literature, look at the latest evidence available for practice, try to do research in subjects related to palliative care. And last of all, when you go back, sometimes you will feel that whatever you do is not changing things, but never doubt that a small group of people can change the world, because it's the only thing that ever has. So thank you very much. And now I'll request Dr. Sri Devi to help me with the queries or the questions that the participants might have in regard to availability in their own institutions. Thank you.
Thank you, Dr. Savita, for the
You are awake. I'm sure half of them must be asleep by now.
Oh, no, I don't think so. You can see all of them and their videos on. So anyone would like to ask a question, you can please unmute or you can type in the chat. We'll wait for minutes.
I'm Dr. Arup Rai Burman, Radiation Oncologist and State Program Officer from Agartala.
Hello, Dr. Arup. I can't see you. Where are you?
Yeah.
I can't see your picture.
Yeah, you can see. Yes. I'm here. How are you, ma'am?
I'm fine, thank you. How are you?
Fine, ma'am. So,
He's our very energetic state program officer.
Yeah,
and
so nice. Your lecture was so nice. Actually, I'm going to start that program. We are waiting for the financial clearance. So in the community involving panchayat. I need your help that time.
Sure.
Already I have proposed and filed all these things. So, ma'am, one thing is that in the MBBS curriculum, somewhere, the topic palliative care should be addressed at least for 1 or 2 hours. Like MBBS life, we read about these things. Dentistry and all other subjects, even radiology posting or something. they should be posted in palliative clinic or somewhere so that they understand. In my state, what you know very well, uh, because we discussed also what problem we are getting, that doctors are afraid to write morphine, afraid to make it available, afraid to say the name even about narcotics and all, because it is all related to narcotics and then punishment and all this harassment, all these things they are thinking. That fear among the medical community will have to eradicate. That is one point from your lecture also. I understood. So, any suggestion for this, madam, from your side? How can we do it?
What I have practice community medicine, when we go out to visit patients in their homes, and we see in the rural areas, all medical colleges have postings in rural areas. That is one area where good exposure to practical problems and practicing holistic medicine with the palliative care approach is possible. Second thing is, I think this new curriculum that has come in does have about 5 hours of teaching ethics, communication, but palliative medicine as a subject, it's not yet there. We are trying. It is submitted to the Medical Council of India, and we are crossing all our fingers and all our toes also that it will soon get approved, and people will be able to study about it in their MBBS curriculum. Because as you said, the change will not come unless it is there in the UG. That's my experience also.
Yes, yes.
I would like to make a comment there. Dr. Arup, in 2019, the new competency-based medical education has mentioned about palliative care, end-of-life care, and many modules on pain management. So Pallium India has developed around 22 modules covering the topics related or comes under palliative care. And we've started training faculties in medical colleges, something like a faculty development program, so that they can go back and teach medical students from the very beginning, starting from the foundation course till internship. So that's something which is very recent, and I think we started only with one batch is we have completed training in March. So that's something which is going to happen in the coming years. So that there is still hope.
Still hope is there. Will work. This is your suggestion, and your endeavor is so appreciable. But then, most humbly, I would like to add that other specialties like surgeons and those who are practicing surgeons and practicing in cancer also during their practicing hours, gynecologists, many others are there. I found, because I'm working, Dr. Savita, madam, my sister, like she knows also, we are working. We need to start curriculum for them also. Most of the times we are targeting the MBBS and the medical. We think that the custodian or the trained person MBBS is sufficient. So even for them, what is ma'am was telling about tramadol, you see, post-operative pain management, they used to give tramadol in most of the times in SOS form, no tapering, nothing else. So there also we need to teach, we need to start the training program or awareness, because many patients, they are not, they will, most of the patients, they will not come straight forward to a cancer specialist or to a palliative caregivers. They will go to other specialties also. This is my humble submission. You all are fighting. We are all are working and getting success also. Thank you. I'm very happy to be part of such a good program, nice program. I think with ECO will start also in Tripura.
Thank you so much. Your inputs are really valuable, that it should be incorporated into all specialties, not just MBBS. Thank you so much for that. Dr. Savita, there is a question in the chat. Do we need any license to distribute morphine in home-based palliative care services?
Home-based palliative care services might need a license if they are going to stock. So if there's an NGO which is doing home care and they need to have their own stock, they need a license. But a doctor who is associated with a hospital say my hospital staff goes and does home care, then they don't need a separate license. No, the license which I have for my hospital is good enough. Is that the question? Am I understanding it right, Dr. Sridevi?
Yes, ma'am.
Arulmoni,
Yes, ma'am. Yes, ma'am. Thank you, ma'am.
Shalini, would you like to add on to that? I'm sorry, I couldn't introduce Shalini. You all know her. We have heard from them, their team, a few sessions back. So they deal with the opioid availability in all the states in India. So I thought it would be very helpful if their team is also there. Shalini, over to you.
No problem, Shreya. Thank you so much. Hello, everyone. Good evening. Hello, ma'am. Dr. Savita, after a long time, listening to you was a privilege. We also have two other regional coordinators on the team. Vishnu and Rajendraji from North and Vishnu from South have also joined. To answer the question, ma'am, of course, what Dr. Savita has said, you don't require any other license if your same institute is giving the home care service. However, depending on the states, we are still trying to cross a lot of barriers. Some of the state drug controllers, or just to keep to be on the safer side, a lot of people are keeping a license or some kind of form with the home care vehicle, that okay, so that they are not stopped unnecessarily in between, that they are giving this morphine distribution. So it's always good to have that form with you in the home care vehicle, so that if by chance any police or anybody stops you, you have that to show them. That was just
Yes,
suggestion.
that's the good thing. And practically, it's always good to take the local police and the local community to the institution for a visit. Show them the work that is being done. Because once they know what it is being used for, they are generally more supportive. Like in Kerala, which has a long history of the community coming together, the police has had a leading role in helping out as far as awareness programs are concerned, or raising funds are concerned. But in states like, say, Punjab, where I was in 2016, people would jump 4 feet in the air once they listen to increasing access for opioids, because the police is on a day-to-day basis facing problems with addiction only. They think only in terms of addiction. Given a presentation in Narcotics Control Bureau, and people told me, madam, we worked here for 30 years without ever understanding the needs of a cancer patient as far as morphine is concerned. So making them aware is very important. That's part of our work, when we are working in palliative care and with opioids, it is part of our work to make different parts of the community aware of why these things are important. And that is helpful for us only in the long term. Thank you.
Thank you, ma'am.
Any questions from the participants?
Hello.
Yes, Dr. Ruchi, please.
Ma'am, I want to ask, in the lecture of state felicitation, you told that you can distribute the morphine on the prescription of the doctors. So in our institute, we are facing the problem that we are not getting the tablet morphine at the end of the financial year. Many pharmaceutical stores, they are refusing for giving the morphine, that the stock is less, and whatever the reasons they have. I want to ask that how much cost will it take for the patients, and how many days, and what is the process if you can distribute the morphine directly to the patients on our prescription? The process of getting like morphine to the patients directly.
Okay, so I should have put it there in the PPT. I think I missed out on the fact that morphine can be sent by courier and by postal services also. So sometimes when we work in remote areas and access is a problem, then we send a hard copy of the prescription to the retailer who has the morphine license, and they send it through courier to the patient. And sometimes they send it only to the doctor. They will not even send it to the patient directly. So I have done it, like I was in Jalandhar, and there was a patient who needed. So this was available only in Chandigarh. I sent my prescription to the retailer in Chandigarh, hard copy, and he couriered the drugs to me, and I was able to give it to the patient.
So, ma'am, like patient has to bear
Does
the
that
cost of
help?
that. Like a patient has to bear the cost of that, and like a little bit detail regarding it. You will give directly to the patient or the doctor.
I think, Dr. Savita, I'll have to jump in here because they have
Please,
already
please
had
jump
a
in, jump in.
session. They have
Jump
already
in.
had a session with state facilitation team, and we did tell them that Pallium India has a telemedicine team here. So whenever a doctor is calling us for their patients to get morphine, we can courier it to them after taking them as a consultant with Pallium India. So, and we will courier directly to the patient and not to the doctor. But your inputs are so valuable. So, guys, now you know that even as a doctor, the way Dr. Savita did for her patient, you can also directly send the prescription to the retailer, and then they can send it to the patient. So you not only have to come to Pallium India, but in your local retailer, you can go to them and get the medicines for the patients directly. And I think, Dr. Ruchi, you are asking for a whole process.
Yes, ma'am. Yes, ma'am.
Yeah, how to, with Pallium India, you're asking for a
With
process?
Pallium India. Yes, ma'am. Yes, ma'am. Because
Pal-
local retailers nowadays they are refusing to give because they have somebody that their license period is over. They are in the process of renewing the license. They have like other different reasons. Local retailers are not giving.
Where
They
are
say
you?
that the
Okay. Got it, got it. Where are you based?
ma'am, Lucknow, UP.
Lucknow. Okay. So you have to find out the list of the
Ma'am, your voice is breaking. You might want to switch off the
if
video for a minute.
somebody is not there in Lucknow, somebody is having it in Kanpur can supply. Somebody who's, in supposing in Murshidabad is there, somebody in Delhi is there. I have had so many. Right? Yes. So do take. It is going to be very helpful in the long run. If prescription, we had to call the retailer and tell them that I'm sending the prescription for this, and they are generally more helpful and supportive. So keep a list of retailers also, and a list of the medicine people who make, like Modi Mandi Pharma is there, Verve is there. So the big companies which make opioids, you must have their contact numbers with you. Hello.
Okay, ma'am.
Got
Yes,
it,
ma'am.
Ruchi?
Yes, ma'am. Yes, ma'am.
There are two questions in the chat. Can a doctor or dentist get trained in the use of ENDs by themselves, or should this be through an RMI?
No, you can get individually trained. Some people are there who have their own clinics and they're not associated with institutions. They can also get trained, but it has to be a certified training. There are a number of institutions within India which provide training, but you need to have a certificate that you've been trained. Sridevi, anything you want to add?
The same. In Kerala, actually, this foundation course is a valid course only in Kerala. Even with this, during the COVID, they validated this course as for which you will be eligible to prescribe EMDs. Am I right, Shalini? This particular question. I think that's only in Kerala.
Yeah, it's in Kerala, but just want to highlight and not to offend anyone, but particularly the BDS doctors, they are not allowed to prescribe morphine. So you can get trained and stock, and you can be the RMI accountable doctor, but you cannot prescribe per se. And that is kind of a rule by MCII, which is still in discussion, and a lot of conflicts are going on. But as per the law, BDS are not allowed, but they can definitely get trained and stock ends.
I think they can prescribe for head and neck cancers.
Oh, yes. Yeah, they
That
can
was
prescribe for a limited. Yes,
and you need to prescribe for that. You can prescribe, but not for any other.
That is what I want to know, ma'am. That if it's a case of oral cancer or any head and neck cancer, can I prescribe by myself, or will I again have to, contact maybe a palliative care setup and then through them get it done? Like,
according to the law, you can prescribe for head and neck cancers, but many places I've got at least 1 or 2 calls in the last few months asking that the pharmacist rejected because you are a dentist. So I told them this is the law. I quoted that and I sent them. For head and neck cancer, in the dental council regulation, it's written that you can treat patients' pain for head and neck cancer. So that's not a issue, but then you have to talk to them. You are eligible to prescribe for that.
But if I am attached to a, a palliative care setup or an RML, that way, then does the scope widen? I mean, or am I still restricted to head and neck only?
You can treat only for head and neck cancer
Only
patients.
head. Okay.
There are a few more questions. If there is a delay in renewal of license, what are the implications? From Dr. Satyajit.
I couldn't hear you. There was a train passing by right at my house.
If there is a delay in renewal of license, what are the implications?
Delay in getting the license.
Renewal of license.
I have to take it because I still have the train passing.
Shalim, would you like to?
Okay, definitely we would want you not to delay it. It's the very first thing. I think start giving your application much earlier from the last date, because it's 3 years renewal that you have. So start renewing in a month advance. You have 60 days period that the state drug controller has to respond. However, yes, if your license is expired and you're still having morphine and you have annoyed a lot of probably authorities, then you are in a trouble. So might as well not do that and keep a renewed license with you always.
I think there was already questions on the pharma companies, and Dr. Savita has responded with some of the companies.
For any particular contact numbers for these companies, I think, Dr. Savita, would you have the numbers for them also?
They
That
are
would be
there on
helpful.
the website. Shalini, we have put them up on the Indian Association of Palliative
IAPC
Care
website?
website.
Okay,
IAPC
okay.
website. Otherwise, yeah, I'll be happy to share whatever I have. So
Sure.
anybody needing that, I could send them across to you, Shalini. You
Sure.
can
Yeah, that'll be helpful for our team also, so that
on the Pallium website also.
Sure. Thank you, ma'am. Thank you.
Yes, we can do that. Welcome.
So the Dr. Vinita is asking about the hands-on training. I'm sorry, it's not today's topic, but I'll just quickly answer. If you want to come to Pallium, just do write to us. When do you want to come? How long you want to come? And we put up a list of hands-on training partners in each state. In the WhatsApp group, you have a document. So kindly, sorry. So there is a document which has been shared in the WhatsApp group on hands-on training partners. You can just go through the list and let us know if you are interested in any of those institutes. You can either contact them directly, or you can tell us that we would like to go there. We have given the contact person's info also in that list. So just write to us whichever way we can help. I think Dr. Savita has lost her connectivity. That's yeah. Any other questions regarding the opioid availability? Anyone planning to apply for the license or the RMI status? If you have any queries regarding the forms, we'll send you a few links, or you can go to the Pallium India website. There is a section called resources. You will get all the forms there. And if once you go through it, if you have any queries regarding how to fill this up, which all forms are relevant, please write to us. Shalini and her team is working on it for many, so they'll be able to tell you how to go ahead with that. Shalini, anything more to add?
I think Dr. Savita is back. Did I see?
I had lost connection. So
Yeah.
back. So I just wanted to add that there's a whole compilation of the documents of the various forms which are required. There was this very nice book by Tata Mumbai, which they had given out with a compilation of these documents which are required. So I think it will be good if we can share with our participants. That would be helpful. They have all.
Yeah,
I
that's
could
right.
send them
National-
across to Raj Lakshmi if you want. Yeah.
Yes, ma'am, if you can do
We
that.
can
Ma'am, your
share
voice
them with
is
the
breaking in
participants.
between. I think if you want to switch off the video, we
I'll
want to hear you. We're not able to hear the audio very clearly. We can't hear her.
Yeah, what I was saying was, Shalini, yeah, that
Yes,
there was
ma'am.
a compilation of the documents required for opioid documentation and getting RMI status. This was by Tata Hospital, Mumbai. So
Dr. Savita, we are not able to hear you.
oh,
Ma'am, is this about the National Cancer Grid document you're talking? Or there is a separate one? I think what ma'am is saying is that she's going to share with us that document.
yes.
So,
I said,
yeah.
the document, you can share it with the participants. That's what I was saying.
Sure, sure. Thank you, ma'am. Thank you.
Any other questions? I think we have finished early today. I think if there are no more questions, we can wind up today's session. Yes, Shalini, please.
Yeah, Shri, I just want to add here for the entire group of doctors, you have had such a good session from Dr. Savita, but if the detailing of the form filling, or you want to know how the state controller is dealing with opioid management in your state, so please feel free to reach out to any of the regional coordinators that Pallium India has. We have each person for every region. They know the state drug controller. They know how the medical institutes have applied. They'll share the samples of some of the licenses with you, and we can clearly tell you whether your state has implemented NDPS Act or not. So there are almost 15 out of 36 regions. So we are total 36 region, including states and union territories, out of which 15 states and union territories have implemented this law completely. So you should not have a problem getting your RMI certificate from them. There are other states where we are still struggling, but we are still trying to work with the drug controllers to start issuing these certificates. So please feel free to reach out to us, and we'll be happy to assist you in any way. Thank you.
Thank you so much. And I would like to thank Dr. Savita once again for attending this session or being a faculty for the session in between all this network issues and travel. Thank you so much. And thank you, Shalini and team, for being a part of this program and answering the queries from your experience. Shripriya?
Thank you, my pleasure.
Thank you, ma'am.
Thank you. Thank you, Dr. Savita, for joining us. Rest assured, without
Thank
that, without that network issue, this was a very wonderful session. And thank you, participants, for making this session so much interactive. And kindly do provide your feedbacks. We have shared the link of the previous 2 sessions. Please do provide your feedbacks because it is very important for us to improve ourselves. And just reminding that the next session is going to be our last session for this particular cohort. This is Shripriya along with Dr. Savita, Dr. Sridevi, and Ms. Shalini signing off from the Deep Sengoha. Sorry for the disturbance in between. So see you again in the next session. Till then, everyone, take care. Bye-bye.
Bye, everyone.